Assalamu alaikum. Today we will discuss on pneumothorax. It is our continuation class. In last slide we showed the special focus on tension pneumothorax. Now we will discuss how to diagnose with minimum exposure and with short time, and how we will can manage this case of pneumothorax as early as possible. In case of pneumothorax, we have to a high suspicion whether it is tension pneumothorax or not. It is our main goal, it is our main focus, because tension pneumothorax have to manage within short time, otherwise the patient may be collapsed and may expire. We can lose the patient. So our goal is minimum investigations and maximum output. Here the support of radiological findings is enough, that is chest x-ray in even remote area, and finds the features of pneumothorax, that is hypertranslucency between the lungs and thoracic case, and here it will shows the sharp border of the collapsed lungs, shifting of the mediastinum to the opposite side of the injury. Other investigations we can do if possible, that is chest x-ray, CT scan of the chest and ultrasonography of the chest. Here the slide shows non-tension pneumothorax. The slide shows the right side, there is ER in the pleural space and sharp border of the collapsed lungs with non-shifting of the mediastinum, that is trachea in centrally placed. So it is non-tension pneumothorax. This slide shows on the right side hypertranslucency on the right side, as well as the sharp collapsing border of the lungs and shifting of the mediastinum to the left side, as well as trachea is also shift to the opposite side. So it is tension pneumothorax. CT scan, this slide shows the CT scan. This is free ER in the pleural space and with sharp collapsed lungs border. Another investigations we can do, that is ultrasonography of the chest if possible. So radiological findings, it is enough to diagnose a case of pneumothorax in maximum case, and we can take a proper management as early as possible within short period of time. Some principle of management: in case of small pneumothorax, no need of intervention. A spontaneous reinflation occurs within 1 to 2 weeks. In case of large pneumothorax in young adults, and if it is primary spontaneous type, needle aspiration is the first attention. In case of 80% cases, no need of intercostal tube drainage. But in case of secondary type, even in the young adults need intercostal tube drainage as well as the treatment of underlying causes. And tension pneumothorax needs intercostal tube drainage. In nutshell, spontaneous pneumothorax in case of young adults we can observe, and needle aspiration in case of 80% cases it is enough. Some cases, around 20% cases, needs intercostal tube drainage. But secondary type, whether it is small or large, whatever it may be, there is underlying disease. So two dimension of treatment, there is intercostal tube drainage as well as the treatment of the underlying cause. And tension pneumothorax, of course, it needs intercostal tube drainage as early as possible. And followed by the management, we have to go chest physiotherapy. Our goal is to improve the distribution of ventilation, to inflate the atherosclerotic lungs area, to increase oxygenation, to increase exercise tolerance and maintain airway clearance. Some concern of a small pneumothorax treatment. Gentle cough can be performed and adequate humidification for ease of sputum, clearance of sputum or clearance of secretion, and reduce exercise intensity. Monitoring the vitals throughout the exercise session is an essential measure. In case of large pneumothorax, adequate humidification will assist the clearance of the secretion. Aerobic exercise should be started like walking, gentle cycling, etc. And avoid a positive pressure therapy like CPAP, continuous positive airway pressure while draining, as well as after 2 weeks to avoid fistula and the risk of recurrence. Should be removed after 24 hours of full expansion and bubbling is stopped. All patients should be received oxygen supplementation accordingly if needed. There are some complications in case of pneumothorax, that is recurrence of spontaneous pneumothorax, tension pneumothorax, hydropneumothorax, pneumothorax, encysted pneumothorax, bronchopleural fistula, pneumomediastinum, cardiovascular compromise, even death, etc. To prevent recurrence rate, we can take some other measures, that is pleurodesis via video assisted thoracoscopy or chemical pleurodesis done by tetracycline, doxycycline, erythromycin 10%, povidone iodine, etc. Thoracotomy is recommended when thoracoscopy is unavailable or it is failed. Smoking is prohibited or smoking is cessation into recurrent of pneumothorax.